just in law, but also in reality. Q7 India has a shockingly high maternal mortality ratio MMR to 167 for every 100,000 births. This is more than twice the target to be achieved under the Sustainable Development Goals (SDG). Why do you think institutional delivery is still a nightmare for majority of pregnant women in India? 250 words. The Wire background to reduce maternal mortality. Reduce India put forward policies and programs in place to facilitate institutional births through Janani Suraksha Yojana, but still large concerns remain. Why is institutional delivery the nightmare? The uptake of these facilities has not increased, and so the number of maternal deaths has not decreased. The lack of adequate staff and quality doctors, especially in rural areas. Indian public health system is unable to provide quality health care to all those who can't afford the private sector. Lack of proper budgetary allocation by government with our spectrum to healthcare services. Even when the services are available, they are of poor quality, which deters people from utilizing them further. Substandard and inhumane care is delivered by healthcare professionals. www.insightsindia.com 52 www.insightsays.com. Women face verbal abuse and discrimination made to deliver on the floor due to lack of beds not provided. Pain relief to avoid prolonged births. Invasive procedures are performed like episiotomy is performed on them without their knowledge or consent. Infrastructural constraints. There is overcrowding in the room with the obstetrician, resident doctor, nurses and interns. In India, allowing a birth companion is usually not possible in a government setup, despite many studies from around the world showing the benefits of having the spouse or a trusted family member present for a smooth labor. In India, cesarean sections are very often seen as a means of making money in the private sector and as a means of quicker labor in the public sector. The intersectionality of physical and verbal abuse and discrimination with caste, class or medical condition also can't be denied. A large section of women that face obstetric violence belong to lower socioeconomic backgrounds. Lack of awareness due to illiteracy and social stigma is still prevalent in some areas. Suggestion: healthcare providers need to be held responsible for their actions and must treat women in labor as autonomous individuals. Budgetary allocation needs to increase. The rural areas' healthcare infrastructure needs to increase, especially implementing ASHA more effectively. Q8 The National Medical Commission bill has to be fine-tuned, especially in planning for rural healthcare. Comment: 250 words. The Hindu background. The National Medical Commission bill is the product of the NIDIAA and was drafted following a scathing Standing Committee report in 2016 on the corrupt functioning of the Medical Council of India (MCI). The bill, if passed, would repeal the Indian Medical Council Act, 1956. How it addresses in planning for rural healthcare. The bill attempts to tackle two main things on quality and quantity, which ultimately affect the consumer: corruption in medical education and shortage of medical professionals so that healthcare in India is efficient. Concerns: the NMC bill misses an opportunity to plan for India's rural health care needs in the coming decades. It eases regulations to set up private medical colleges, a move that will hopefully produce more doctors. This measure isn't enough as there is a severe shortage of doctors and most of them are concentrated in urban regions while close to 70% of Indians live in rural provinces. Due to this, rural people rely on informal healthcare providers training non-doctors. The focus is still largely on MBBS doctors as the best means of healthcare delivery in isolated parts of rural India, ignoring the evidence from countries like Mozambique and Thailand which show that training non-doctors can be a safe, effective and cheap way to provide life-saving healthcare when no doctors are available. A bridge course allowing alternative medicine practitioners to prescribe modern drugs is mentioned in the bill. Unscientific mixing of systems and empowering of other practitioners through bridge courses will only pave the way for substandard doctors and substandard medical practice. This will seriously impact patient care and patient safety. It will cripple the functioning of medical professionals by making them completely answerable to the bureaucracy and non-medical administrators. www.insightsindia.com 53 www.insightsays.com. The nexus between the unqualified practitioners or RMPs, rural not registered medical practitioner, is apparent, but bill neglects this. Cost of medical education would increase, and also the bill makes it easy to setting up of private medical colleges, leading to rise of unskilled doctors. Suggestion: the bill does not address how India would produce enough competent doctors to meet its evolving healthcare challenges and how can it minimize opportunities for rent-seeking in medical education and practice. There is a need for more elected members in the commission, but with limited terms of office, so that corrupt members aren't re-elected. International example, there is a need to keep the NMC free from political influence is for an independent body like the Union Public Service Commission to select its members. Such a model is followed in the U.K., where the Professional Standards Authority oversees the selection of members to the General Medical Council. Clear guidelines are required indicating the circumstances and diseases where traditional practitioners can prescribe allopathic medicines. A new system of community-based trained health workers, not government employees, who are enrolled on the state medical register is needed. This can only be done if the medical education law provides for it. To bolster healthcare delivery, there can be a 3-year diploma for rural medical care providers, along the lines of the licentiate medical practitioners who practiced in India before 1946. Conclusion: the bill needs to confront reality and address it, keeping